Welcome everybody to the Rayner Lunch Symposium. I'm very happy to see you all today for this, I think, excellent session. We will talk about how to improve post-operative outcome in cataract patients. And I think the title sounds very abstract, but you will see with this wonderful panel, we will try to give some lift to what we are actually talking about. We want to give you some very tangible tips how you can actually improve the post-operative outcome. To introduce my panel just very briefly, we will talk about each person individually, but to give it a brief introduction, we've got Professor Thieme from Magdeburg, Professor Gatinel from Paris. This is why we're also talking in English, not in French. We talk in English so that everyone is on the same page, and Dr. Lena Beckers. So what we will do is basically we will give brief talks. Each of us will talk around like 15 minutes, and then we'll get a session where we'll actually discuss about how to improve the postoperative outcome. So I think the magic happens really in the end, where we have got the chance to talk like half hour together. I mean, we've got experts in refractive surgery in the audience, and we've got some experts in the panel, so we can really dig into it and see how we can improve postoperative outcomes for our patients. So without further ado, I go to the first person. I would like to introduce Professor Thieme. It's really a pleasure to introduce him. He's our former president of the DOG. He's committed to telemedicine and AE applications in ophthalmology. He specializes in anterior segment surgery, especially complicated cases in glaucoma, including childhood glaucoma. I think actually this is, my deepest respect, because I think this is one of the most complicated areas within anterior segment surgery. So I'm really looking forward to your talk. He is committed in expansive lens implantation in challenging cases of all ages, especially focusing on glaucoma in young patients. He's a member of the board of the glaucoma section of the German Ophthalmologic Society and active in the nationwide self-help initiative, Glaucoma in Children. And fun fact, if I may say so, before studying medicine, he trained as an aircraft mechanic in England. In his lecture, Professor Thieme presents the advantages of PROMs, so patient-reported outcome measures, with the Rayner platform RayPro. His presentation, Harnessing PROMs for Patient-Centric Ophthalmic Care. Professor Thieme, please.
Thank you, Dr. Shajari, for this kind of invitation and introduction. I also salute my co-speakers who will speak after me, and I salute you for attending this meeting. Thanks for coming and being informed about what I have to say. My English is a little bit, but it's not very long since I left England, so I need to, it might be a little bit sloppy by talking in English. Harnessing PROMs for patient care, ophthalmic care. There's an abbreviation in this sentence we're going to talk about, and I would like to share a few things I experienced while doing cataract surgery, not glaucoma surgery. You're not coming here for glaucoma surgery, but for cataract surgery. These are my financial disclosures. This is actually a very trigger-happy Herr Heesch, können Sie mir helfen? Das ist mir zu trigger-happy. Soll ich das benutzen, die Maus?
Maus benutzen.
Okay. So, the overview. As you know, as past president of the DOG, I was entwined with an online conference for the DOG. So I take quite fond interest in paving the road to digital to ophthalmology. And I'm very interested in how internet changes the patient's life. I will talk about RayPro and PROMs. We're going to give you an explanation, also the problems and challenges we had at Magdeburg to starting a study using these two tools for us to enhance our understanding of what we do as cataract surgeons. The results and outlook will be the last part of my talk. I think the road to digital ophthalmology is already on the way, and it's very much been enhanced and pushed forward by the corona pandemic. Think about the fact that we never talked about Zoom or WhatsApp conferences, and we've changed our life completely through this corona pandemic, and the need for increased telemedicine was just obvious. There were loads of video consultations I performed myself with patients whom I couldn't see because of the pandemic. And also the fact that we rely on high-resolution imaging devices which contain high data volume forces us to think other ways than just looking at everything separately. Artificial intelligence in ophthalmology goes parallel or went parallel with this, but I think it's going to play an important role in the future for our understanding of how ophthalmology and diagnostic procedures are taking place. And also the patient awareness and using internet and Dr. Google, I might say, is enhanced dramatically. The patient wants to know what's going on and refers to the internet first, often first. If you look at these images, I don't want to go into detail in any one of them, but what you can imagine is that there's loads of data enhancing our understanding and knowledge about ophthalmology and what's going on in a timeline in the patient, if you look at the OCT images, for instance. The problem we are having is that we need to funnel these data to something we can use as doctors, as practitioners in the ward, in the station, or in the praxis. So what are PROMs really? PROMs are patient-reported outcome measures. This means that the patient reports by himself, by the internet, of what is going on in his life. And the reason we are using this tool today goes back to the fact that the study landscape changed dramatically in the past 10 years. For instance, a questionnaire about quality of life was never ever heard of when I studied medicine. No one was interested in quality of life in a patient. The results were visual acuity, pressure, visual field, etc., etc. Quality of life changed that dramatically. The PROMs, don't force me to tell the sentence all the way through. The PROMs are actually an online questionnaire. And the reason why it's so significant for us is not relied only on the Rayner lenses or this company, but on all intraocular lenses we can use. It's so far manufacturer independent. It's a tool you can use even if you hate Rayner lenses, which I don't because I'm implanting Rayner lenses in 30 years. And it's an automatic data pool creation that occurs that you can handle in order to find out what the patient really is he satisfied or not. The access to the results is open, so you can, once you're linked in, you can actually use the tools to what you want to see your benefit for the patient. So, in the old days, I might say, the CAT prompt questionnaire was a couple of sheets of paper the patient had to print out, put on top in front of his desk, and make crosses. So these are the old analog days for the analog dinosaurs like I am. So this is, for instance, one of the questions. Your bad eye is affecting or interfering with your vision overall, and you can cross wherever you think it's correct for yourself. Interfered with your life in general here. Quality of life aspect is shown here. And the question, I don't want to go into detail on all the questions, but it's a very straightforward, very simple to answer for everybody so that you can actually make the cross on the right panel you're choosing. Or in the last month, has your eyesight decreased? Or do you have troubles? So this is the analog way. And what Rayner has done is that this CAT-PROM questionnaire is now available in the digital form. And this is something that then feeds its data in the RayPro data pool. So the patient is not filling out forms with a pen of paper and crossing crosses on a piece of paper. He sits in front of a computer and clicks into the program and goes through these questionnaire digitally, of course. And the person sitting here is actually myself, but I have no need for cataract surgery yet, and I haven't had one yet. So this is something the patient looks at. It's very easy to read. It's large language. It's a button design process. You can skip the button from 1 to 10. And it's very simple and easy to manipulate the data into the data pool. I would like to show you a video of how RayProm appears when you are using it once the patient has put in data from his surgery. So you can actually, with an access, click onto RayPro and look what the page, is the patient happy, is he satisfied, or whatever question you may have with your performance. You can even ask RayPro, is the patient satisfied with your surgery? Which is an important issue for me. I mean, I would like to know, once the patient leaves the house, was he satisfied with what I had done?
RayPro, the only
Can we,
data-driven,
Mr. Hayes, can we
patient-reported
pump
outcomes
up the
platform
volume, please?
Designed for ophthalmology, delivering real-world insights on spectacle independence, dysphotopsia, and outcome satisfaction using the clinically validated CAPROM 5 questionnaire.
Can we proceed, or should I? So what you can see here is you actually see lots of data and analysis. You can look at it very calmly in front of your computer, and you could already see that some of the data questionnaires reflected in the icons you see. I'm sorry for the tech. Can we have a way to because it was linked to the.
Listen, here.
RayPro provides quantifiable, actionable, and insightful patient-reported feedback over 3 years. Podium-level data in clinic,
Spectacle independence,
customized to you, adding never-before-available detail to your
over the
patient
month
conversations
and later years.
performance of the different IOLs you use.
Okay,
Harnessing the power of big data,
we can stop that. I think people have seen everything they wanted to
as
see.
reported by patients, against up to 2 other IOLs of any make and model, presenting the results in this intuitive and easy-to-read IOL
Mr.
comparison
Shajari,
view.
you are still in time.
RayPro automatically sends patients 6 short questionnaires at specific times over 3 years post-surgery. The RayPro platform makes setup and data entry as simple as possible. RayPro, long-term, real-time, patient-reported insights.
Okay. Now, what you have seen is that these data are collected over a period of 3 years. So the patient needs to be in continuous reporting his experiences. There are no visual acuities in this, in all these data, and everything that usually comes from a study as we are used to look at. And they are still available, of course, and very important to be performed. But you as a surgeon can look into this platform and scan through what the patient needs and wants.
RayPro.
Okay. Can we proceed one slide? Next one, please, Mr. Hayes. Okay. No details here, but look at the number. 6,000 patients have reported. So it's a huge data pool. It's not only a few numbers of the patients you have operated on, but huge numbers of data you can look at. So we started PROMs and PROs in RayPro in Magdeburg with a little study and created first an information leaflet. And we tried to recruit patients on a stationary basis and also outpatient basis. Again, this is in a university clinic, and we do about 400 stationary cataracts and about 400 in an outpatient basis. So it's not a huge number. But however, well, I wanted to know how patients are affected by this study and also how they respond, or whether they respond at all. Most of my patients come from rural areas and not from the city of Magdeburg where I live, but they come from all over the place around the cities. And most of them are difficult cases, and I was wondering how these would they report at all? The information leaflet looked like this, and again, it's important, the patient needs to understand that the study aims for their satisfaction, how they are getting on with what has been performed. And you can see here that actually the timeline up to 3 years is listed, and also that the CAT-PROM 5 questionnaire, which I just explained to you, is part of the game, so to speak. Of course, we want to know that the patient is not just satisfied and sitting in front of his computer, but also needs to report when anything goes wrong during that time. Again, this is also our and your work to look after the patients after cataract surgery, but the questionnaire is actually taking this in consideration. These are the Magdeburger PROMs and problems. I'm quite openly saying that in the area I live, I'm talking about the area around Magdeburg, and Magdeburg area around the rural areas, not alone specific for Sachsen-Anhalt, so to speak, but for all over the place. We have these parts where no internet is accessible in other parts of Germany and Europe. 25% have no email address, and many of them were not willing to take part at all. I want to hang on here for a minute to explain. This is my worksheet when I go for surgery on a Monday. This is outpatient basis, not stationary. So I make a list, and you can see here, the last one had died by the time I wanted to perform surgery on him. Okay, so he was listed for surgery, and of course, again, couldn't take part. And you can see here, I'm IOL independent from Rayner. I can use whatever lens I want. And you can see here in the remarks that some of these people are not easy cases. This is never, ever California cataract, what I do. This person might raise an iris retectors. Who would make outpatient patient surgery like this with iris retectors? Well, I do, all the time. I know nothing else. Vision blue, nice to have. If you haven't got a red light reflex, you use vision blue. So these are the not easy cases. And again, we started in April, and no wonder I haven't got 3 years result, right? So because we had just started, all I can see is the surgeon's satisfaction is quite high. So I'm glad. But I can't tell you all the other details, but we will continue to perform these analyses in the future. So I asked Mr. Kakotka, he's a very, very good assistant he wanted to make a doctoral thesis in my clinic, and he started in April 2024. And I asked him, well, call up all these people who already had lenses implanted, but all these people he asked, he telephoned around, they didn't want to know. So when you want to take part in this study, you have to do this in beforehand. Ask the people to take part before the surgery and not after. So 103 were enlisted. You can see about half were not with an internet and are not willing to take part. So my outlook for the future, it's a very good tool for you to use, for me to use. We will continue the recruitment and we will further evaluate the technique in the future. And the decision-making for what you do in surgery depends very much on the results as I see it, because the patient is satisfied with one lens, is spectacle-free with the other. And so you have a path to follow using that program. Mr. Shajari, do you have 30 seconds for a very short video, I promise, that shows ambulatory outpatient patient I did surgery on? If you want, I will, because I gave birth to a lens you haven't seen before. And this patient has what we called cataracta nigra. You ever seen one? It's very common in my area. All my senior house officers are able to perform this surgery. It is trained on a regular basis. This is cataract surgery. Okay? So I made it very quick, and I still keep this lens in a little plastic bottle, and many others. I'm thanking you for your attention, and I will answer any questions you may have about the program once we have the panel discussion. Thank you.
Yeah. Really, thank you very much, Professor Thieme, for this wonderful talk. I mean, like, it's unbelievable that there are so many patients without emails even. I
was
really
surprised too.
Yeah, I'm really surprised to see this. And I mean, like, if I see the kind of cataracts you do in this type of Magdeburg, I mean, like, it's still Germany, right?
Yeah.
And there are like so many patients with this kind of heavy cataract. It's unbelievable.
Well, these are the facts, and I was surprised to find them.
Yeah.
Because I never looked after them. But this kind of surgery, you will have to learn. All the youngsters of you in the panel here, you will have to learn this because it's coming.
Yeah, true.
Thank you.
Okay, thank you very much. So we will do the discussion at the end of the session. So now I would like to introduce wonderful Dr. Lena Beckers. Dr. Lena Beckers is going to give us a presentation about vision correction with less compromise. She trained at Breyer Keimer Klabe Augenchirurgie in Düsseldorf, where she specialized primarily in refractive surgery and eyelid surgery. Subsequently, she attended the University Hospital Hamburg-Eppendorf and afterwards started the cataract training with the Augenärzte am Rathaus in Hamburg under Dr. Mathiesen. Her special interest in ophthalmology is cataract and refractive surgery, so that's good. Yeah, it's a good session then. Dr. Beckers strengthens the team of precise vision ophthalmologists in Rayner since January 2024, together with her husband, Dr. David Beckers, who I think also is here, correct? Alongside Dr. Florian Kretz. So, in her lecture, Blended Vision Correction with Less Compromise, she will present the results from the research group with Dr. Breyer on the RayOne EMV table. So I'm really excited about this because I think this is one of the most interesting subjects for the audience, right? We would like to see how the EMV performs, especially with blended vision. So, Dr. Beckers.
Thank you, Professor Shajari, for the kind introduction. Today, I may present our clinical results using the RayOne EMV in a blended vision strategy called the Düsseldorf formula. So first and foremost, I would like to talk a little bit about the lens itself. So as you heard before, the RayOne EMV promises a depth of focus of 1.5 diopters using positive spherical aberrations. And at the same time, it promises to keep a high quality vision with low dysphotopsia, high contrast sensitivity, and thus a high patient satisfaction. So last but not least, and topic of this talk, are the possible treatment options by using monovision for an advanced spectacle independence. So for everyone who can't or don't want to remember physics class, spherical aberration is a phenomenon where the periphery of a lens bends the light stronger than the center does, and this way a depth of focus is created, which in case of the RayOne EMV is 1.5 diopters. I even brought along a little bit more physics today, so here you can see the results of the RayOne EMV under the optical bench. The modular transfer function of the RayOne EMV compared to a monofocal IOL demonstrates that the RayOne EMV firstly provides a high quality distance vision, secondly a smooth myopic redirection for an enhanced depth of focus, and thirdly a hyperopic extent, which provides a wider landing zone when aiming for target refraction. But not only this hyperopic landing zone also provides a seamless transition of vision when using monovision. So how monovision with the RayOne EMV can work out is shown here. Again, demonstrated by looking at the modular transfer function. You can see how different amounts of anisometropia turn out with 0.5 diopters, 1 diopter, or 1.5 diopter offset. And this last graph presents the Düsseldorf formula and presents what we wanted to test in our clinical study to see how patients handle an offset of 1.5 diopter using the RayOne EMV. So for us, this is not a new principle. For over 10 years, we used the so-called Düsseldorf formula in patients who are reserved when it comes to multifocal IOL, but still seek a high degree of spectacle independence. We originally used a refractive EDOF IOL with a near addition of 1.5 diopter and a targeted anisometropia of 1.5 diopter. So we could also demonstrate that this anisometropia does not reduce stereo acuity of our patients. Now we performed the same principle with the RayOne EMV. Therefore, we did a retrospective analysis of 84 patients, which shows after detailed informed consent whether they wanted ametropic vision in both eyes or the Düsseldorf formula. So 38 patients wished to be targeted for ametropia on both eyes, while 46 patients were in the cohort that was targeted for anisometropia according to the Düsseldorf formula. 3 months after surgery, we looked at the refractive outcome, corrected and uncorrected, and asked the patients from the blended vision group to perform a quality of life questionnaire with a series of questions to determine the quality of their everyday life after refractive correction. So to build up a little bit of tension first, I will start only with the ametropic results. As you see, patients achieved an excellent distance vision of 1.0, a good intermediate vision of 0.7 at 1 meter and 0.5 at 66 centimeter, and some sort of functional near vision of 0.25 at 33 centimeter. For the average patient, this itself shows a superiority compared to a monofocal IOL, with an improvement especially in intermediate vision, what is already worth a lot, thinking of the rising importance of intermediate vision in a time where we all spend more and more time looking on our smartphones or on PC screens. But how about the blended vision group? Just to remind you, this is what a classic monovision with a monofocal IOL looks like. And here you see the Düsseldorf formula. It is supposed to work in theory with a nice transition zone. But in practice, we got even more surprising results. While keeping excellent distance vision, the Düsseldorf formula shows a superb intermediate vision with 0.85 at 1 meter and 0.9 at 66 centimeter, and at the same time, a good quality near vision is upheld. Even we were surprised after these results, because when comparing them to the ametropic data, you see a superiority in distances where the lens does not mainly aim at. You see that the defocus capacity uncorrected is even better than it is corrected, and it is very evenly distributed to provide a seamless visual transition. We theoretically tried to explain these findings and played a little bit with the graphics. The graph which is most important to us when evaluating our results is this one, which shows the real-world data without correction. You can see again how evenly distributed the visual acuity is, providing a seamless visual transition. Our aim was to compare this data with what was expected. Therefore, we needed to transform our graph a little bit more, and ta-da, we were able to adjust it so that we could compare it with a modular transfer function. So the real-world data compared to the theoretical data of the optical bench shows that the lens even under-promises what it actually delivers binocularly in a blended vision strategy, and shows great advantages for the patients, especially when looking at the intermediate vision, but also when looking at the near vision. We tried to find an explanation. So various papers in combination with different IOL, which all contain different optical principles, showed the possibilities of binocular addition and visual acuity compared to monocular vision, which we think is the main explanation for the excellent intermediate vision. To give you a little sneak peek for the last talk, Professor Gatinel will show you that the RayOne EMV can, under certain circumstances, provide even more depth of focus than it promises, which could also be a possible explanation for our clinical results. Also, a study published by Labous et al. Looked at different EDOF IOL types and their performance under the optical bench. Here, they pointed out that the RayOne EMV showed a more extended range of vision than the other mono EDOF IOLs. The authors also already discussed that a laboratory setting has its limits to predict real-world data, as for example, binocular summation always influences the results achieved with these IOLs. So our results do now give proof of concept to this benchmark study and shows that the real-world data enables an even higher defocus capacity than the results out of the laboratory would suggest. Summing up, we see that in a blended vision approach, patients achieve an excellent visual outcome for distance and intermediate vision, as well as good functional near vision. Quality of life questionnaire showed a high degree of patient satisfaction for the blended vision group, and no patient complained about photopic phenomena or problems driving at night. And the last 2 points are especially important, as the study from Labousse et al., I mentioned on the slide before, suggested potential halo phenomena with the RayOne EMV, and we could not confirm this theory as our patients were not troubled by any photopic phenomena. So we used the questionnaire recommended by the ESCRS, while we have to admit that we are really looking forward on working with Ray Pro next year, what focuses even more on visual outcome, as it was already wonderfully presented by Professor Thieme. I do not need to speak about it more in detail today. And as a conclusion for us, even though we think of it just as some sort of branding, the RayOne EMV is more like a true EDOF IOL than a monofocal IOL, and in a blended vision model, it is ideally suited for an everyday life without glasses for the most part. Reading small print won't be possible, so that is important to inform the patient before surgery that no complete spectacle freedom can be achieved this way. The question we got asked a lot on the RayOne EMV was which patient is really suitable for the lens, which we can answer simply by returning the question which patient is not suitable. And I'm already looking forward on discussing this question with the rest of the panel after this session. So thank you for your attention. And I am now delighted to introduce the next speaker of our session, the moderator himself, Professor Shajari. He is owner of Dr. Vision in Frankfurt, senior physician for refractive and cataract surgery, and works at the University Hospital in Frankfurt. He is one of the focused top doctors in Germany for refractive surgery and cataract and corneal diseases 2024, and Professor Shajari has been ranked in the world top 50 researchers several times in recent years for the areas of astigmatism, cataracts, and refraction. He is a committee member of the European Society of Cataract and Refractive Surgery, and he also volunteers as ophthalmologist at Orbis Flying Eye Hospital. Yeah.
Thank you very much for your very kind words, and especially for your great presentation. I think it was really insightful, and I think there will be a couple of things which we will later discuss on regarding especially the amount which you should give between both eyes. So I'm really looking forward to that part. Let's start with the presentation. So what I would like to talk with you today, because it is actually something which was interfering with myself, how to get started and develop your practice with RayOne EMV. I just started 1 year ago my private practice, and so this was like a real life question to myself. Before we get, however, to the question how, I would like to discuss with you why. And this is the lens distribution in my patients. So you see, I'm doing some monofocal lenses, I'm doing some trifocal lenses, but the majority of the lenses I implant at my private practice, they are actually lenses with a depth of field. So let's get more into the question why this is, what rationale is behind this distribution. If I look about my own experience with treating presbyopia, there is a huge issue which we have, because we are trying to give aesthetic solution to a dynamic problem. This is something which a colleague said once, and I think it really summarizes everything together. Because what we have is basically accommodation. So this is something which is dynamic. And now, no matter what we do, all the solutions we are currently using are all static. Whether we are doing monovision, whether we are implanting trifocal lenses, or whether we are implanting depth of focus lenses, all of them are static. And what this means is we have to obey to some extent to the laws of physics. And what results in that is that we need to get into some kind of compromise. And with we, I mean actually our patients. So we are taking basically the responsibility to discuss for our patients what would be in their best interest and where they could live with the compromise. And if I think about it this way, this will actually lead you to the result why I'm choosing so often depths of lenses. The treatment options we have is monovision, depth of field, or multifocal. Monovision has got its restrictions, and I think we already saw in the presentation of Dr. Beckers what she just described with the advantage of summation when we are doing monovision, but this has got, of course, its limitations. Summation is basically when you're seeing with the one eye 0.8 and you're seeing with the other eye also 0.8, but when you open both eyes and the refractive power isn't so distant within both eyes, you get the summation. So you can see binocularly better than with each individual eye. So you see with both eyes 1.0. And this is up to a difference of 1.3 diopters within both eyes. If you go beyond this limit, so if we say, like, for example, we would like to implant a lens which is minus 2.5 in the one eye so that we get really good near vision, and the other one goes for the distance, we get something which is subtraction. So this means if I see with the one eye 0.8 and the other eye 0.8, if I open up both eyes, I will actually see worse. So I would see, for example, 0.63 because of the subtraction. And if we go even beyond 3.5 diopters, then we've got suppression. So this means like one eye will take over the lead, the other one will almost get like excluded. So this is what is really important when we are talking about monovision. There are specific restrictions. And we also have to know that just up to 1.3 diopters, we actually still have got stereoacuity. So we know there is a restriction in monovision. With trifocal, we have got just issues because we know there are specific laws in physics, and trifocal means trifocal. So if you get the same amount of light into your eye, but you distribute it into 3 different areas, you will have got, of course, less light into each individual area. So this means you have got a drop in contrast sensitivity. There is no way around. And the biggest problem with trifocal lenses is actually you need completely healthy eyes with a flawless optical property. Because if you imagine the situation that you've got a complex optic, which is basically distributing the light into 3 different areas, and then you've got the cornea, which has got its own irregularities, you will just get stray lights over and over again. So it's really critical that you have got the clean cornea. And this is a bit different to the situation when we are talking about depth of field. Because, you know, when you're maybe doing like some photo shootings, that you can actually decrease the aperture, and by decreasing the aperture, you get depth of field. So you can see basically in a bigger extent. Of course, you will still lose contrast sensitivity, but you can see in a bigger extent, and the image gets sharper. So you will see in each individual area actually better than you would see with an open aperture. And this is a big contrast to when we are talking about, for example, trifocal lenses, where you need a flawless optic. Actually, with lenses which are using this aperture, for example, you could even treat highly irregular corneas, yeah, to get like a better and clearer vision. So now let's get into the situation of spherical aberrations, because this is what we actually would like to talk about, the EMV. And this is now something which is very interesting in regard to spherical aberrations. And this is that it is known to our brains. It is very different from the situation when we are talking about trifocal lenses, because there the brain has to learn this new way of processing images. This is why we are talking about neuroadaptation. You don't have this spherical aberration to that extent because it is known to our brains. Because it's in our cornea, it increases with age and it increases with accommodation. And it is a symmetrical aberration. This is very, very important because we know that our brain is able to process better higher order aberrations as long as they are symmetrical, as in contradictory to asymmetrical issues, like, for example, coma. When you have got a coma, we all know if our patient has a coma, it's a huge issue for them when they would like to see at something. It's different with symmetrical higher order aberrations. This is now a slide which I took from Professor Einstein, and I really love this slide, and I couldn't improve it in any other way, so I'm just using his slide really in this section. Because what he shows is actually you are seeing that we have got patients from 0 to -2 diopters, and how actually they would perceive a reading chart. And then he adds spherical aberrations to the same patient and shows how this actually can improve your visual acuity in each area. So, except of course in 0 diopters area. But you see, like, for example, when we are talking about this section, we cannot read what what is standing here. We cannot see these 5 letters, but when you add some spherical aberrations to it, you actually start to see, even in this kind of defocus, a clearer image. Of course, we will get something which is lost here at the beginning, but because our brain is able to process spherical aberrations quite well, actually patients are much closer to this than to that. So now the question is, if spherical aberrations are helpful, should we just increase them limitless? And the answer to this is, of course, no. There are specific limits to that. So we know the more spherical aberrations we add, the more depth of field we have, but also, of course, we decrease our contrast sensitivity. There is actually what Professor Alfat says, there is no free lunch in optics. Yeah? So if you increase depth of field, you will reduce to some extent your contrast sensitivity. But we are saying like, okay, to an extent, it makes sense for our patients because maybe they don't need all the contrast sensitivity, but they will benefit in their everyday life from the depth of field because they can then maybe read without spectacles. But what is important in this graph is this at some stage stops. And this is at 0.6 micrometers of spherical aberrations. When you go beyond this level, then you will get a decrease in contrast sensitivity, but at the same time also a decrease in depth of field. So there is really no benefit to going beyond this limit. The other thing which is really interesting about that is that it works in both directions. I mean, this was something which was super interesting to me because it doesn't matter whether you're adding positive spherical aberrations or negative spherical aberrations. Both can actually increase your depth of field. So let's get back really to basics. What are the spherical aberrations of our cornea? What is the average spherical aberration of the cornea? How does it change when we are performing laser surgery? What happens when we are doing myopic laser surgery? What happens when we're doing hyperopic treatments? These are the questions which are really fundamental and which I would like to answer. So first of all, let's get back. Positive spherical aberrations means that the peripheral light rays are bent more than central ones. So that's very critical. Periphery bent more than the central ones, positive spherical aberrations. This is how the cornea in the majority of the population is. The average is 0.27 micrometers. So we know we have got like a clear, basically buffer zone to our limit of 0.6. And the standard deviation is 0.1 micrometers. So this means the normal population, so 95% of our population, will lie somewhere in between 0.1 micrometers to 0.5 micrometers. It increases after laser treatment for myopia because, of course, we will reduce the central power. Yeah? So it will basically increase, and it will decrease after hyperopia treatment because we'll do some steepening. So, and this actually, I think, makes very clear what is the advantage of the RayOne EMV. Because so far, what most producers tried to do was to reduce spherical aberrations. And the reason for this was, we said the average cornea has got 0.27. So I will do, for example, minus 0.25 in my lens. So I will increase the contrast sensitivity. But as you are increasing the contrast sensitivity, you will lose the depth of field. And this is where I think Rayner did really a bold move because they went the other way around. They said like, okay, look, we know that this system could actually work in our advantage, that it can give us the amount of depth of field which will help the patients to be, to some extent, spectacle independent. Now the question is, can we go even a step further? Can we introduce something which is called blended vision, basically, and comes from, we know it, Professor Einstein, for example, does it a lot with laser patients. You actually basically give one patient's distance vision and do some depth of focus, and you give him the other eye at minus 1.5 and give him again depth of focus. So what you will achieve with that is you get a good distance vision, you get a good near vision, and you have got a blend zone. But does it actually work for lens surgery, or is it a good way to go with this 1.5 diopters? And I think this is what I said. It will be a very, very interesting panel discussion, because what is the perfect limit, or what is basically the perfect difference between these both eyes? Because in my opinion, there are some things which are a bit different when we are talking about lens surgery as compared to laser surgery, because the prediction error in lens surgery is significantly higher than in laser surgery. Even most sophisticated approaches do not get more than 80% of patients within 0.5 diopters of target refraction. Residual astigmatism is quite high usually, much higher especially as compared to laser surgery. Post-surgical correction is with a lot of more risks. Yeah, I mean, like this is something when we do a LASIK patient and we need to correct a little bit, it's just a touch-up. Yeah, it's no additional risk except maybe some epithelial ingrowth, which is also very unlikely if we are doing it the correct way. But it's a totally different situation when we're talking about lens surgery and correction. And the most important point, everyone who is doing blended vision with laser surgery knows that there are a lot of pre-surgical tests necessary to see actually whether the patient is fitted for such a big approach or for basically for such a bold approach or not. And this is simply not possible with a patient who has got cataract. So you could do it with refractive lens exchange. I myself, I don't like to do refractive lens exchange, but with cataract patients, it's impossible to get the same level of basically pre-surgical examinations as you would need for this kind of difference. So in my opinion, you should maybe do a smaller step. Yeah, so you should, if you're doing blended vision, I think it's a correct approach. I think it can benefit a lot and we can use the benefits of the depth of field lenses, but you should take maybe just a smaller step of 0.75 diopters. And now with the last slide, I would like to actually give an answer to the first question, how to start. And these are the things which were, like, for me, important in the first year of in this private practice. The first thing is be very specific when you're talking with your patients about their reading requirements. Because if you ask a patient, would you like to read? Every patient will say yes. Okay, but when you get into the more specifics, what's really important to them, it's not necessarily the 2.5 diopter distance. It's not the 40 centimeters. Most of my patients, when I tell them, like, look, would it be sufficient for you if you're in a restaurant and you can read the menu? Yeah, that's what I want. I want just some independence in my everyday life. Would it be okay for you if you would then still wear reading glasses when you have to read a lot? Yeah, it's no problem. It's no problem. I just want, in my everyday life, I would like to have got some spectacle independence. So be specific about the reading requirements. In my opinion, difference between both eyes should be 0.75 diopters. Target refraction in one eye, of course, emmetropia, and the other one minus 0.75. And always choose the first eye plus a bit. Treat dry eye symptoms before, stabilize the tear film before taking measurements, because it's really critical if we are even now starting to give some difference between both eyes to have got correct distances. Personalize your constants. I personally use Olsen ray trace. It gives me so far the best results, but of course, whatever you use, just optimize your constants. Alternatively, you can use, of course, Peer2Peer formula, which is specifically done, and I mean, like, he's the inventor of the lens, and they optimize the lens factor, so it's not anymore like you can actually now rely on the lens factors of the formula, and you will land correctly and not anymore into the myopia level. Then pay highest level of attention to astigmatism. We didn't talk about it so much, but it's actually one of the most critical areas when we are talking about depth of field. You need to basically correct as much astigmatism as possible. Try to work always on the steep axis. Tell patient upfront about capsular tension lines, because also here nothing is for free. The RayOne is extremely, extremely stable when we are talking about correction of astigmatism. So it's one of the few lenses which I would say keeps their position. But the one thing is, what you have to know is, because it is so stable, it also causes some kind of capsular tension lines. So I always tell this upfront to my patients because it's no problem, and it resolves within the first 3 months, but you just should tell them upfront about it and not like afterwards. Exactly. So always perform subjective refraction and do not rely on autorefraction. We'll be a bit in the minus section. In my opinion, leave at least 1 week before surgeries just to see whether you landed correctly. And always test uncorrected visual acuity in the distance and in the near. Because if you are doing just refraction, you will be really surprised, because of the phenomena of summation, how much the lens will forgive. So instead of looking always just for the refraction, rather look for the uncorrected visual acuity in the distance and in the near. And if your patient is happy, your patient is happy. Thank you very much for listening to my talk. And I would like now to give over basically to someone who doesn't need an introduction in the field of refractive surgery, Professor Damien Gatinel. He's among the world's leading experts in refractive surgery and heads one of the most advanced cataract, corneal, and refractive surgery departments in Europe at the Rothschild Foundation Hospital in Paris. He's the author of more than 200 publications in peer-reviewed journals and the owner of several patents. And now something which is really impressive to me. He's the co-inventor of the first trifocal IOL and developed a new classification for higher order aberrations in his doctoral thesis in applied mathematics. With his colleague Alan Saad, he developed an AI system for detecting aphasia-prone eyes, the SCORE analyzer. And together with Dr. Debil Mania, they created the Pearl DGS IOL power calculation method. In his lecture, Professor Gatinel will explain how the laboratory measurements can help clinicians with their patient selection for advanced technology IOLs. So, Professor Gatinel, stage is yours.
Thank you very much. It's a pleasure to be here. I feel a bit sad that you have all to speak English because of me. I studied German when I was younger, but I forgot it, so I will try to resuscitate my German during this stay here. This now will be focusing on the patient selection for advanced technology IOLs. I want to acknowledge some financial disclosures, but I didn't receive any money from Rayner to show you some results that I will cover now, because in my department we pay a lot of attention to the exact optical features of the IOLs. You know, companies, they usually use nice semantics, but we feel that sometimes those semantics are disguising the truth. And with my PhD student, Benjamin Stern, we are using this instrument that is a wavefront analyzer. So we take every lens we can receive or buy, and we analyze them using a fancy optical system. And if you were last year at the ESCRS Rayner Symposium, I'm sure you were all there. But if you weren't, this was the conclusion. That is, this chart is a bidimensional plot of the pupil size influence on the x-axis and the corneal circular aberration on the y-axis. So it shows you that when the pupil constricts or dilate, or when you have a patient with a specific amount of corneal circular aberration, the depth of focus, which is plotted in color, and the warmer, the poorer. So good colors are blue, red, and yellow, and bad is red, is shown here. So you see the green was here in an eye for the average pupil diameter and the average spherical aberration, which is nice, right? But this again shows that you have this kind of a sweet spot of 2.5 depth of focus. That can be the highest you have with the average spherical aberration and pupil size. And on average, the Rayner lens shows a depth of focus of 1.5 or more over the outer range of pupil size and corneal diameter, because this is mostly yellow, and yellow is about 1.5 diopters here. But that was again for one power, which was 20.5. So what would happen for different IOL powers and different eyes? I was interested in this recently published paper, which just gives new clinical data in eyes of patients that had this Rayner EMV lens. And we have the demographics of these patients here. And more importantly, we have the information we would like to analyze, which is the pupil diameter and the corneal circular aberration. Of course, these patients were selected to have a kind of normal bandwidth for circular aberration. But yet we have some numbers here we can refer to. Again, pupil diameter, photopeak and mesopeak, mean, standard deviation and range, and the corneal circular aberration means standard deviation and range, but again, in a normal kind of a setting. This is what we had with the EMV lens, but now we have more information, because not only we have a 20.5 dioptric power lens, but we have in this study lenses that range between 16 and 25.5 dioptric power. But what we wanted to do is to even cover the extreme spectrum of lens powers, which is usually, as you can really, in those eyes, from 10 to 30. And of course, we took 20 as also a reference. And we used the NEMO system to again vary the pupil aperture, vary the corneal spherical aberration level, as you can see, not only towards positive values, but also towards negative value. And we use those numbers from the clinical study for pupil and spherical aberration as a reference to start with. So you can see we have different plots here depending on the power of the lens. It looks like immediately that if you have a higher power, you will have a better depth of focus than if you have a low power lens. And first, let's focus on the study reported spherical aberration levels. You see usually comprised in this kind of between the two white lines here. And also let's focus on the average pupil size and extreme photopeak and mesopeak pupil sizes. So first, the photopeak mean pupil size here is, as you can see, regardless of the power of the lens, you always have a yellow or even colder color, which is good. And it's going to be even better if you move towards the side of higher power lenses here. So with an average aperture size and the photopeak condition here, all three lenses achieve at least 1.5 depths of focus. And if you move towards the higher power lens, this is even higher than 1.5. With the now mesopeak diameter, which was 5.4 in this paper, still, as you know, has been said nicely before, the pupil diameter is also influencing the depth of focus. But even if you dilate it here, this is the yellow box, the purple box, vertical. You see that we still have more or less more than 1.5 dioptric power of focus. And again, the highest can be in this 30 dioptric power kind of a range of patient, where you can almost reach 2 to 2.5 dioptric power of depth of focus with a small pupil in particular. So I think that's interesting because it shows the robustness of this IOL to the power, and also some tendencies that is hyperopic eyes may be more having higher power lenses, so they will probably be more easier to satisfy. This is again something which was in a study for the average kind of a population, and this is interesting. But we are facing now a wave of patients that had LASIK, PRK, or even SMILE in the past for myopia or even hyperopia. And you know, those surgeries, they alter the corneal spherical aberration. So we found interesting to address this question: what is the impact of increased beyond physiological or below physiological, if you speak about negative ones, levels of spherical aberration? Again, these ranges are shown here. Above like 0.4 micron for a 6 millimeter aperture is probably a post-myopic corneal refractive surgery eye. And if you go below 0.1 or even on negative side, which is not that much physiological, you have those hyperopic corneal refractive operated eyes. And what would be the effect of using a Rayner lens in those particular eyes using those kind of same pupil ranges? So let's start with the one that had hyperopic surgery. So, you know, we make the cornea steeper in the center, it gets to be flatter in the periphery, it becomes prolate, and it generates corneal negative spherical aberration. As you can see here, there are more red colors, which is not good, but still for most of the pupil, especially the small pupil diameter and the average one, still we are doing fine, and we can be in an interesting range of at least having 1.5 depths of focus. But be cautious with eyes with a very low power lens and a large pupil diameter. But on the other hand, these lenses may be very alien because it's not very conceivable that you would implant a 10 dioptric power lens in an eye that had a kind of a hyperopic surgery, because this is a short eye usually. Even if you have increased the corneal power, you probably not will see those kind of ranges, but still it's interesting to understand. Now focus on maybe the most frequent situation, which is an eye that was operated with a LASIK, PRK SMILE, KLEX, we say now, or LALEX, for a myopic era in the past. Still, for again those pupil apertures, which are the average photopic, the average mesopic, and or even the smallest pupil mesopic and photopic sizes, you can see that there is only a bad zone, which is for low power lenses and large pupil diameters, and somehow increased positive corneal spherical aberration. But again, it's probably not very common or even plausible that you would implant a 10 dioptric power lens in an eye that was operated with LASIK for myopia, for example, because even if the cornea has been flattened, even if the actual length is long, probably the lens power will be always around this 20-25 dioptric power range. But still, again, these are theoretical in vitro measurement, but we can learn from the tendencies and maybe apply them to the clinical situations. Again, if you have an eye that had a LASIK surgery or PRK for myopia, you will find good results if you have to implant a high dioptric power lens, which can happen if the cornea is very flat. This shows you that the higher the dioptric power of the RayOne EMV and the more positive the corneal spherical aberration, the higher the chances you will achieve a good depth of focus, especially for average to small pupil diameters. So you see, this is not only now addressing powers, it's always looking at the whole situation more comprehensively, corneal spherical aberration, pupil range. These were, of course, again, in vitro bench studies, but these can also translate clinically into depth of focus and contrast sensitivity. And last year, Vienna ESCRS, which I'm sure you all remember, we had this lecture from Professor Oliver Findel, which compared the contrast sensitivity with the VVT lens, I think. And this was in black for the Rayner lenses, the curves you see here, and in red for the Alcon VVT. And you can see that on average, it seems that the Rayner lens was achieving a better contrast sensitivity in this population. So in vivo, this is an interesting finding, I think, for those who are implanting this lens. So in conclusion of what we found in our lab study, what can we say? On virgin eyes with average pupil dynamics and corneal spherical aberration level, we showed that the RayOne EMV can achieve a depth of focus of at least 1.5 diopters for most of the IOL power, and the higher the power, the better. Smaller pupils and hyperopes, because they have higher power lenses, will achieve greater than 1.5. That's what we predict theoretically, and we invite you to confirm this with your patients in the future. In eyes that had previous LASIK, SMILE, PRK, whatever, for myopia, a case-by-case approach is recommended because, again, you must measure maybe the corneal spherical aberration and maybe try to estimate the pupil levels of the patient. The smaller the pupil, the better it will be. And again, just beware of patients with low power lenses, but that's not going to happen, again, for biometric issues. For eyes that had hyperopia surgery, again, also most of them will achieve 1.5 dioptric theoretical depth of focus. But again, be cautious with always those lower power lenses, which are probably, again, not very frequent in those eye category with short axial lengths. And again, yet, despite those variations, potentially you can achieve 1.5 diopters of depth of focus. Again, I said that in also previously, post-myopic refractive eyes for myopic initial errors will probably reach this minimum level of 1.5 dioptric range of depth of focus, and get also cautious, be cautious with eyes with a very low power. But I've never seen an eye that had previous myopic surgery that you have to implant with a 10 dioptric power lens, or it's probably a very extreme alien eye that you should be cautious with anyway, even for IOL power prediction. It's going to be tricky. And of course, this is again in vitro, but I think it's a very good basis. There's kind of a lot of maybe gap or distance between in vitro and vivo, but I think in our community of doctors, we lack in vitro objective evaluations. And on this, I think it's important that company collaborates with this and maybe lower the level of semantics creativity to focus more on what a lens can achieve in terms of optical performance in various clinical or theoretical situations. And this is what we really try to do with our bench analysis. So we are covering, again, the whole market. We try to. And in the future, we will try to bring to the community those results of our analysis for this. So maybe in your clinical environment, you can derive some conclusion or make some prediction and improve your predictions and more importantly, improve the level of satisfaction of your patients. Thank you very much for your attention.
Really wonderful talk, and I think a very, very complex subject, which we will now deep dive into. Before I give the questions to the panel, I would like to ask you, are there any questions from your side? So please use the microphones and use the opportunity to basically discuss this quite complex subjects together with us. Otherwise, I will start maybe the first questions. Lena. You showed very, very interesting your last slide where you said, like, okay, the question is rather when not to perform. Is, in your opinion, such a monofocal plus lens, is it an option for the daily practice? Is it a lens which we can use mainly in all patients?
Thank you. So this is a very interesting question, because what I love about refractive surgery is to find always the best lens suitable for every patient and to go for the individual approach. But when you think of one lens that is suitable for most patients, I think that the RayOne EMV is very suitable, as long as you screen for the pupil size and the spherical aberrations of the cornea, as Damien pointed out so perfectly right now. As it is rare to find someone that is not suitable, yes, I think you only see advantages, especially in the intermediate vision compared to a monofocal IOL. So yeah, you could go for that.
What would be your limits in the terms of pupil diameter?
Damien pointed out more than 5 millimeters. I think it's rare to find one that is like over 5 millimeters. What we screen for more, or where we find sometimes a patient that is not suitable, is the corneal spherical aberrations, as we are a bit more, we only go to 0.4. Yes, not 0.63 actually. We are not so brave as you are in Paris.
Do you actually go to 0.63? For the pupil, you mean? Yeah, no. The spherical aberrations like this.
0.63, I'm sorry. Well, we didn't have to do it clinically, but I think, again, if the power of the lens is high, it's better. But if you have a low power lens, it may be too much, as shown in the slide. I think 1.6 is already a lot of positive circular aberration. So probably with a regular lens, even an aberration neutral lens, you can get some positive circular aberration in a sufficient level to increase the depth of focus of the patient, especially if the pupil is not so big. Something which is not also, and it's not there, but I'm triggering Rayner curiosity, is the impact of ACD, the anterior chamber depth, which has probably an influence on the depth of focus. In all I showed you, the lens distance to the cornea was almost the same. But I think there are papers and simulations showing that if you have a narrow anterior chamber, you have more depth of focus than if you have a large one. And that goes with the result. That's not contradicting, because as I showed you, the higher the power, the more the depth of focus. And the higher the power, usually the smaller the eye, because you need to compensate for the actual length. And the smaller the eye, the smaller the ELP or ACD. So, but still it would be another variable, but that would require us to do three-dimensional plots, because pupil spherical aberration. ACD would be a bit complex to represent, but still we can keep that in mind. Maybe next year for the next Rayner Symposia, we go for that. I like this topic because it deals with IOL power prediction, where the prediction of the lens position is critical, as you know, to determine which power you need in a patient. So,
would you also then, so basically what you're saying is when the anterior chamber is less, we get more depth of field?
Yeah, there is a tendency. If you go on the internet, there's a paper published in 1984. You can get it on ResearchGate. It's open access. I don't remember the type. It's Japanese team. They made a calculation to see what was the influence of K, ACD, and pupil aperture on the depth of focus of an eye. And they came with an equation. And if you read the equation, you can understand the influence of those variables. So I invite you to find this paper. If you email me, I will give it to you because I like this. It's just an equation and you see what influences what. And I think the ELP was, as I said, the lower, the higher the DOF.
Very, very interesting. And actually, I think it's a good transition to the question I've got from Professor Thieme. Because yeah, I mean, you show very bravely what type of surgeries you perform, and it's really amazing. And I think you're absolutely right with what you just said, that basically surgeons need to be able also to do like complex scleral surgery. Yeah, this is what we need, like a scleral tunnel. And with someone who's performing so much complex cases, what is your opinion in the situation when we have got not the standard eye? What is with, for example, beginning glaucoma? How do you see the situation with macular degeneration? How would you approach those?
Well, thank you for the question. First of all, I'd like to point out that I'm intrigued to be here because usually we never look over the plate of the board of the plate, right, so to speak. So der Tellerrand gegenüber. We don't do that usually. So I do here today, and just this topic about the anterior chamber depth and depth of focus. The anterior chamber depth never interested me at all because I was just looking at anterior chamber depth because of the intraocular pressure, right? Mm-hmm. So when you take a lens out, which is very thick, and the anterior chamber gets deep, we have a better IOP. So we need to look over the border really, so to learn more. Now for special lenses, I call them special lenses. In my clinic, I usually have a high rate of regret. I push people further away from special lenses, and the rejection rate is about, and when I talk to patients, about 75%. Mm-hmm. In your practice, it might be the opposite way around. Yeah. Because I don't like unhappy patients. I've done more multifocal IOL explantations by myself than I implanted in eyes because they are usually referred to me. Well, they usually refer to me as glaucoma patients who shouldn't have received a multifocal IOL in the first place, but they get implanted for whatever reason. I can't imagine the reason, but I usually take them out and put a monofocal in, and the reason is because the accuracy of any lens is impaired anyway when you have a glaucoma patient or you have someone with AMD. And with the glaucoma patient, it's very tricky because the first scotoma in glaucoma is not an absolute scotoma, which is, black, we get from the visual field. It is a relative scotoma right next to the center of vision. And you put a monofocal lens in such an eye, and the glaucoma gets worse and the visual field decreases. They are actually on the opposite side of effect. They are really bad, and the people complain. And this is why I've taken them out. Mm-hmm. And taking a lens out a couple of years later, I mustn't tell you, it's not a nice thing to do. So as far as glaucoma surgery is concerned, I'm cautious about whichever eye needs trabeculectomy, for instance, or other scleral, I've said huge scleral effect of what I've done. But this patient, he had basically cataract nigra on both eyes. This eye had light perception in all the right way, and the other one was by 0.05 visual acuity. And his wife was reading his newspaper for the last 10 years or 7 years or so. And this eye, with this technique, no matter what lens is inside, don't get me wrong, whatever what lens is inside, he was happy because with this technique they jump up to 0.63 or something like that. Because without phaco, you don't have any effect on the cornea. With this technique, you just slide the lens out, the bag is intact, you put a lens in, and he falls around your body, and you get kissed by these people. So, but it is very interesting for me to listen to these talks, because I usually don't. So I'm happy. I was happy to be here. Thank you. Very good words.
Okay, questions from the audience? Okay, Damien, I actually have got a specific question for you. Yeah, because I mean, like you showed us very, very clearly you are implanting also this kind of monofocal plus lenses in refractive surgical treated patients. What are the most important things, what you think are really critical in order to get good results? Like, what kind of formula do you use? Is there something specifically what you're doing in the type of surgery to get better results?
Thank you. For those eyes, I think, again, the challenge is to predict the actual best IOL power. One good point is that with positively aberrated lenses, and that's opposite to other lenses like INs, where there is negative circular aberration. You know, the human eye refraction is more or less driven by the central refraction. And if you have depth of focus, it means you have a variation of the power. So listen carefully to what I say. If you have negative circular aberration in an eye driven by an IOL, if the eye is emmetropic in the center of the pupil, which is what brings distance vision quality, then the patient will have less power, so he will become hyperopic in the periphery by definition of negative circular aberration. Then you cannot have good depth of focus, right? So this patient will not be happy and will probably have decent distance vision, but not near at all. What you need in those lenses is to have a central myopization, which is not set by companies, but they try to disguise it by increasing the IOL constant, or telling you, oh, your autorefractometer showing minus 1.5 is not working at all. It works very well, because the eye is negative in refraction in the center, and what makes negative circular aberration is to reduce the power towards the periphery of the pupil, so that there is more and more distance quality vision, because rays are less deflected. So again, the center is more for the near and the periphery is for the distance. But that's usually not excellent for distance vision. This is why you cannot achieve distance, intermediate and near. You can just play a little bit. And that would interfere with IOL power calculation if you think about it. So with Rayner, I don't think there is so much to do with this, because again, the center of the pupil is emmetropizing, because the increase in power comes with the distance from the center to the periphery of the lens. Okay. That's one thing. Second thing, for the IOL power specifically, of course, I will be biased and invite you to use the Pearl DGS, which is available online at iolsolver.com, or Google type Pearl, like a Pearl DGS. And we have a specific calculation for we call complex eyes, which include post-refractive surgery eye, and we differentiate between myopia, hyperopia, and radial keratotomy, which is again another area because of the posterior corneal surface deformation due to the incision. So that would be the formula, of course, recommended. It's on the ESCRS website, but that's not for post-myopic eyes. So you need to go on a specific website. But of course, formulas like Kane, Barrett, Evo, K6, I gave all my friends' names. I don't want to have issues with this, are also working well. So what you should do maybe is compare many formulas in those eye and try to see where they converge to. But this is, to me, the most challenging thing in our practice, because we are doing LASIK, K-legs, and tomorrow on the same patient, if we live enough, or if, like Lena, you are very young, you are willing to do cataract surgery later on these patients. And this is very interesting to decide which lens we can use, which power we should implant. And every week in my cataract surgery list, I have one or two eyes that had corneal refractive surgery before. Already about 20% are computed, which is huge, right? And I think in the future it will be maybe 30% because the prevalence of refractive surgery grows. Those eyes, they have cataract earlier because they were myopes, and they are more demanding because they were spectacle-free, and they have this mindset of, I don't want spectacles. So it's challenging in many ways, and we should very focus on those eyes. And the Rayner lens, without being too flattery to Rayner, is one that you can really use with confidence in those slight atypical eyes, because as I showed you, the positive circular aberration is working well even with non-physiological levels of positive or negative circular aberration to a certain extent. Just beware of low power lenses, but in those eyes they are not very frequently implanted.
Can I have a question as a glaucoma specialist? Now, I operated on a patient pre-LASIK, and I used the wrong formula, no matter what, and I'm out about a diopter with what I wanted to achieve. Would you? It depends on the case, of course. And glaucoma patients, they really don't want to be operated on a lens twice or three times. So. Would you opt for like a sulcoflex Rayner lens, which is slid in the sulcus, to correct? Again, it's a very broad question. We should pinpoint, but in general, would you opt for it, or would you take it out and put a new one in?
I think
it can go to both.
Yes, of course. I will say, and we can have a collegial answer. If the patient had glaucoma, I'm not sure you should put another lens. So I would, in those eyes, most of the time, I don't change the lens. Okay. I just leave the flap, because I'm a refractive surgeon, so it's not a problem. Okay. And I do a little fix. So, as I said, it's a challenging issue, but
yeah, all right.
Yeah, I did a laser fix. Every patient that had LASIK, that I do surgery on, I expose the patient to this possibility that there will be the necessity for a flap lift and laser ablation, so they have to put aside extra money for that. But that's my answer. I think lens explantation and implantation in those eyes is tricky. Yep. Lena?
I actually agree. I would also just do a lift, like a re-LASIK on him to get this one diopter corrected. But if this patient wouldn't have glaucoma and it's just that he's after refractive surgery coming to you and you are not sure which formula to use, or you are not sure you will really get your target right, I think that the RayOne EMV also, I don't want to flatter too much Rayner, but it's a nice lens for that because it has this wide landing zone. So I think sometimes it's even especially good for our post-refractive surgery patients. If you don't hit the target perfectly, the landing zone can save you with it.
Okay, and sorry. And the flap was done in Turkey like 20 years ago. That's the usual case, all right? It's been done somewhere, sometimes, for whatever money what.
Then, of course, be sure to do an OCT so you know where the flap is and that you can lift it up again. So.
I feel like there is also the one thing which you need to consider in such cases is epithelial ingrowth. Yeah, if it's like such a long time and you know like that it's a rather older patient, you have to be sure that it was a clean cut basically, yeah, and you will not get an issue. I don't know, I think like if it's just an add-on lens, yeah, it's also not a bad option. I don't know why it should have got an issue with a glaucoma patient if you are just, I know that we will decrease a bit the anterior chamber, but I think it's so minimal, and depending on the level of amount where you have been on the wrong level, and if there is no astigmatism, I think also an add-on lens would be a good option. If you have got some kind of astigmatism, I would clearly tend toward laser surgery. Otherwise, I think the add-on is also a very, very good option for these cases. So I think we come to an end. If there is no further questions from the audience, thank you very much for listening till that moment to us. Thank you very much for the wonderful speaks. It was really, really very insightful. I think it was a vast majority of different kind of subjects. We saw very complex cases. We saw what we can do actually with the lens, how we can like improve evenly these hard tools, what we have to get even more out of the lens. And we saw what we can do in very complex situations after what you are saying is getting more and more every day, laser refractive surgery. Thank you very much for listening to us. It was a wonderful, sincere pleasure.